Hi, everyone. Welcome in. Good to see you all. Some lovely familiar faces. Um, yeah, we are excited about this lunch and learn, this casual chat, just kind of sharing our thoughts and ideas together about how to best collaborate between pelvic floor physical therapists and sex therapists. Um, and so thank you for coming. This is recorded. We're going to share the recording later. It's going to be in about uh, a week or so, hopefully less than that, when it'll be available. And for those that have signed up for CEs, I will email you the CE link. You just fill out the evaluation, and then you automatically get the certificate in your inbox. So yeah, we'll get started, and we'll let people in as they come through. Uh, so we'll start with Dr. Karah Charette. Thank you, Dr. Karah. Karah is from Bodyful Physical Therapy in Oakland, California. Karah, do you want to share a little bit more about you?
Sure, yeah. Thank you for having me, and nice to see everyone here. Yeah, so I'm a pelvic floor physical therapist. I co-own a practice. My colleague Dr. Marissa Steffen and I started our practice about 4 years ago in Oakland. I would just say briefly, I think what makes our practice a little more unique, at least to the Bay Area, is that we are very somatic in our approach. So we're all things pelvic floor, and then we are both dancers and currently training in the somatic movement modality of body mind centering for folks that may or may not know that. So I think that's the thing I feel called to name is just when it comes to the nervous system, acknowledging that, being trauma informed, that's very much our specialty. Thank you.
Thank you. And then we have Dr. Julie Sarton from down south in Tustin, California. Hi, Dr. Julie.
Hello. Thank you again for hosting this. Oh my gosh, I love the collaboration. So I am also a pelvic floor physical therapist. I've been around for about 30 years now. So one of the pioneers of a practice down here with 2 locations, with 7 therapists. And I myself have suffered with pelvic pain and endometriosis, and through my journey have definitely learned what I call now like the Sarton systems method is that no system works alone. So when I built the team here, I really brought in as much of that true collaborative nature as possible. So besides our pelvic PTs, we also have a guided imagery therapist, an acupuncturist. We have a master Pilates instructor. We have something called Red Cord for neuromuscular re-ed. And then I wish we had psych. This is the one missing piece we need. So we work closely then either collaboratively off-site, but we even have had people come on site too. So we treat people from of all ages, 8 to 80, and all genders.
Wonderful, thank you. And then we have Marjorie Boggs Vazquez, LMFT from Rouse Relational Wellness. Hey, Marjorie, how you doing?
Good, yeah. Hi, as David said, Marjorie Boggs Vazquez, LMFT. My pronouns are she, they. And I work at Rouse Relational Wellness with individuals and in relationships. And the way that this sort of pairs with what we're talking about today, I focus on sex and intimacy as well as trauma. And so those things all really overlap, especially where it comes to intimacy and relationships and also sort of healing from sometimes traumatic kink injuries or sometimes more moving through histories of sexual assault or intimate partner violence and how that can show up individually and in relationships.
Thank you. And Marjorie also did the workshop a couple of years ago, Sex and Intimacy for Survivors of Intimate Partner Violence. It's a really good workshop. It's on Rouse Academy. And then we also have Emerald Aueyong, AMFT, APCC, who also did the workshop on working with interracial couples therapy. Hi, Emerald.
Hi, David. Hi, everyone. Thank you for being here. And thank you for the introduction, David. As David said, my name is Emerald. I'm an associate sex and relationship therapist under David's supervision. And I treat both individuals and couples as well. And the way that this this collaboration shows up in my work is I frequently refer to pelvic floor physical therapists, and there's such a wonderful community there as well. I treat interracial relationships, desire discrepancy, communication challenges, and as far as individual work, I love working with sexual trauma survivors or any form of trauma, dating, neurodivergence, and anxiety and depression as well. So I'm very happy to be here, and hopefully our insights can help you all. Thank you.
Wonderful. And then take a look at the, the attendees, the folks that are staring at us. We got lots of LMFTs and PhDs, PsyDs, other folks in the community. So if you want to put in the chat, who you are, where you're from, this is a good networking opportunity. And we only have an hour. I feel like we could do like a full day, multi-day, one day. We'll do a little retreat sometime. So let's get started. So I want to start us off with just demystifying pelvic floor physical therapy. I won't be doing that because I'm still learning lots and lots about it. And we just had Dr. Julie come and talk to us the other day. Learned a lot over there. But Dr. Karah, Dr. Julie, if you would like to share, what is the pelvic floor, anatomy, key functions, and what does it do?
All right. We'll just tag team this. Does that sound good, Dr. Karah?
That sounds good.
So a picture is worth 1,000 words. So I've got a few models here. So the pelvic floor, I'm gonna, just for ease, I've got both, I have a male penis owner and vulva owner model here. So I'm going to hold just this one up for ease. So collectively, we call this group of musculature the pelvic floor. It sits at the basin of the pelvis, essentially attaches from the base of the spine, from both your sacrum tailbone. It wraps around the anal opening and comes around and wraps around the vaginal opening and attaches to the front of the pelvis, the pubic bones here. You literally are connected also hip to hip, right here and here, through this sling of musculature. So, really quickly, these muscles, I think they're the coolest muscles in the world because they play such a huge role across 5 different key life purposes. Number 1, stability. So with every step we take, they're firing. They work with your back, your abdominal wall, and your diaphragm. Number 2, support. They hold up all our organs. Number 3, a sexual functioning. So they need to be able to have normal, healthy tone and length, and they need to have good strength too for orgasm and then for penetration with the vaginal vulva, right? So we need both ends of the spectrum for muscle health. And then they also have a sphincteric role. Well, they'll close the sphincters, whether urethral or anal sphincter. And then the last one we call is like a sump pump. So these muscles like this, they go through their full range of motion. They actually help with the lymphatic flow and the vascular flow right through here. So they sit at the crossroads of the body. I love to say all roads eventually lead to the pelvis. There's just so much we can go on and on about, but I'm gonna pass the baton to Dr. Karah, so you can keep going.
Amazing, thank you. Yeah, that's a great overview of the anatomy, and I feel like I have nothing to add to that. Maybe just in the spirit of the community we're sitting in, and just my passions of connecting through a somatic lens of, I just don't believe in the binary of the body and the mind as being separate things. And so one thing I feel called to name is that beyond all the functionality, what I find really fascinating is just how much this part of the body can very much be linked to a felt sense of safety. And so what I think is really interesting is, though I'm always very clear about my scope and I'm not trying to be anyone's psychotherapist, and in fact I'm always referring to psychotherapists, I just love the fact that I feel on a cellular and muscular level that for people to be able to connect to this part of their body, I've seen it actually help inform deeper senses of safety and then contribute to what might be going on psychologically and vice versa. So just to name that other piece, and I just think everyone deserves to feel connected to this part of their body, dysfunction or not. It's part of the core, and it really influences our nervous system.
Yes, that's beautiful. I think what makes these muscles, because they are skeletal muscles, just like every other muscle, even more unique, and just complementing what you just said, Karah, is that they're governed by the autonomic nervous system. So our patients who have had trauma, our patients who have been like dismissed, right? And so the trauma can be any type of trauma, even just medical trauma too. The pelvic floor, because of that autonomic nervous system governance, it will contract and respond without physically anything changing. And so a lot of practitioners don't understand that. And that's so important for practitioners and patients too, because they have a lot more control than they realize. And here's the blending of our worlds that's going to come in together too, because we'll get into like what treatment looks like, but that's where we always start. Because if we have a patient that has a very dysregulated nervous system coming in, I always love to say your nervous system will beat our hands every time. Like we've got to get that nervous system dialed in into a safety zone, right? And that can look very differently for different people. But it is like where we have to start, number one, first and foremost.
Amazing. Thank you.
And then what would be, I guess, for all providers, what would be some like red flags or indicators that pelvic floor physical therapy would be useful or like a good referral?
I mean, I'll just say quickly, just to bounce again off what Julie had mentioned in the beginning, to make it really simple for any provider, if a client reports any type of urinary, bowel, or sexual dysfunction. A lot of providers here are working specifically with sex and intercourse. So hopefully, more language is coming out around there. And I always say, pain with sex is not normal unless you want it to be, right? We're talking about being kink friendly. There are people that are okay with that and want that. So always being careful with the language around this. But yeah, any type of dysfunction, for all genitalia, it can be erectile dysfunction, pain with penetration, pain with orgasm, lack of orgasm. I think Julie mentioned the muscle function is huge for that. And then, yeah, things that I think get normalized in our culture. So people be like, oh, I just like pee a little when I sneeze or cough. And it's like, okay, that might be common, but that doesn't mean it's normal. And so to just not normalize these things, even if it's not disrupting their quality of life, it is a sign that the pelvic floor might have some dysfunction and that could worsen, not to be fear mongering, right? But just to get ahead of it while it's something that's more mild. So that's what I would say is bowel, bladder, sexual function, and then also core, back, hip, because as you saw with the pelvis and the anatomy, the things that are nearby, and that this is so central, things that might be classified as more orthopedic. If you have a client who's like, oh, I've tried PT for back pain, hip pain, but maybe they didn't have their pelvic floor assessed, we can actually provide another lens. So those are my key things.
Beautiful. Yes. We discussed this on Wednesday, but I don't know if we can drop this, David. We sent you guys a digital form, but if you want to drop this also for everybody to see, because we just made like a little cheat sheet that we will give to patients and providers too. So basically, how many can you relate to? And it's exactly everything, like the dysfunction of what we treat is related to the function of the pelvic floor, as Karah said, but like we just said, do you have low back pain, right? So we get tons of people that come in with low back, SI joint pain, tailbone pain, who've been to ortho PT, didn't respond. So, but most doctors and providers aren't looking at, oh, the pelvic floor actually has a referral. We talked about the pelvic floor being the great deceiver. Pelvic floor has a lot of referral patterns. It can send signals elsewhere. The brain will interpret the pain as the low back, but it really is actually coming from the pelvis, okay? And so because the pelvic floor can manifest, right, what we call like either trigger points, top bands, they can send pain elsewhere where the brain goes, ooh, I have pain there. But unless you know the red flags, you're going to miss this piece. So yeah, so pain with sex, orgasm dysfunction, like you said, the leakage component. So the bladder, bowel dysfunction, chronic constipation, so not just incontinence, but also being able to, with both bowel and bladder, urinate and defecate normally without straining. So spinal, and then pre and postpartum is another big issue too. And there's where some people will experience trauma as well. either like a traumatic birth. We've treated plenty of women. So, but yeah, we'll make sure like this is a quick cheat sheet. So we just have people circle and we're like, if you answer more than one of these, you need a pelvic floor PT.
Yeah, and I'll go off and piggyback off of what you were both saying. I actually had a list of things like how would I refer to a pelvic floor physical therapist and what issues do I see that where I typically would refer them out to a pelvic floor PT. And coming from the mental health aspect of things, every time or anytime a client talks to me about erectile dysfunction or high anxiety during sex, and if we have talked about the anxiety during sex, and there's a physical component that I cannot reach, and I don't touch clients, so we can only go so far as the psychological aspect of things. That will then signal me to refer them to a pelvic floor physical therapist who particularly works with men and are very comfortable with working with them as well. Another area where I would also refer out, or like something that kind of flags or signals me to like maybe there's something deeper going on, is yes, with that painful sex component, if they also have difficulty with insertion of any sort of item, so that can be anything from a tampon to finger to toy, and then just imagining penis, right? The girth of that. So I would also flag those things too. And then, yeah, I love that you both mentioned the lower back pain, digestive issues. It's a very holistic approach that I take as well. So that's where I would refer out to a PT. Yeah, I don't know if I answered your question, but yes, I think I kind of encompassed the other things. Oh, the last one too. Yes, sexual trauma. So I have referred most of my sexual trauma survivors to a pelvic floor physical therapist because, yes, while I can help process the trauma itself, a lot of times there is that physical component of getting back into a relationship where sex is present, and seeing a pelvic floor physical therapist can really help with the self-esteem aspect as well. I hear that pelvic floor PTs can also help with reconnecting your mind-body connection. And that's something where a hands-on approach might be more beneficial for the client. So yes, those are my inputs.
Yeah, absolutely. I mean, just piggybacking off of what everybody else said, right? Yeah, when I see those kinds of, and again, I also, support a lot of folks, not only with like sexual trauma, but also medical trauma. And I also support a lot of folks who have chronic pain and chronic illness issues. And that can be much more holistic and, of course, can also be tied with trauma. And so, again, kind of keeping in mind what are the things that feel like could be something that I can support with, but keeping in mind those sort of not markers that something more physical could be happening, and suggesting checking in around like, okay, well, do you have access to a pelvic floor therapist easily, right? Like, do you need to go through your primary care physician? Are you open to being referred to somebody like that we would refer you to, right? Like being able to have all of those different connection points available for people as well, because of course we want to make sure that the access is there for everybody.
Wonderful. And I have a question for the pelvic PTs. I have a friend who's a medical physician, and she talks about how she's often lately been getting patients that come in and say that they have chronic inflammation, and that it's kind of this word that's been used around, and that she has to do a lot of kind of funnel questions to figure out, okay, what's going on. And another term that I've heard is tight pelvic floor, but then I've heard other PTs kind of add a lot of nuance to that. And I was really fascinated by it. And if you know what I'm talking about, if I'm setting it up right, can you share more about like the definitions of that? And like there's the tight and weak and hard, or yeah.
I mean, I'll jump in as like just a very anti-binary person that
Yeah.
like it just the rhetoric for me around like you're either weak or tight, and so if you're weak you have to strengthen, or you're tight and you need
Right.
to relax, it just doesn't work because it's not functional. So it's like, yes, we can try to figure out, and I'll tell you, at least in my clinical practice, 99% of the time people are actually dealing with dysfunction because there's too much tightness. But I also don't send people home saying, oh, never contract your pelvic floor, because like Julie mentioned, good luck. Your pelvic floor has to turn on when you walk, when you push a door open, right? It's part of your core fear-based behavior because they feel like they can never turn their pelvic floor on again. So right away, first day, I'm talking to people about the health and vitality of muscles, particularly of the pelvic floor, being so deeply connected to the core and breath. The definition of health in this part of the body for me is constant movement and the ability to get in and out of positions, to be coordinated, to have conscious awareness, right? And then we might veer if someone's in a lot of pain. Yes, the beginning might be that we need to do more breath work, more relaxation, but I'm mostly teaching everyone how to fully contract and fully relax, because we want it to be that pump system. We want it to be able to bring blood flow in and out, massage nerves, all of these things. So I tell people, let your jellyfish swim. Like the pelvic floor is supposed to move, it's supposed to swim. Yeah.
Yeah, it's so interesting because I've seen over the last 30 years, like the trend initially when pelvic PT first started was everyone was like, biofeedback, biofeedback, right? Like do that, where essentially patients would come in, they would be connected with a probe that would go in either transvaginally, transanally, and then it would measure EMG output. And they would be instructed, a lot of physicians did this actually, and had nurses do this, and they would be instructed to Kegel, right? Let's Kegel it with the theory of like, we're going to contract that thing and we are going to make it fatigue out to let it go. So then finally people started understanding, oh, muscle physiology, like basic muscle physiology of any muscle is if I have a shortened or overactive hypertonic, right, or the tight, there's all these different words, right, that makes it a little confusing, pelvic floor, but essentially it's like the pelvic floor, my bicep is like already here, and I'm sitting here doing this. Is that really going to help? Are we fully going from a mechanical standpoint with actin and myosin cross bridging that creates a muscle contraction? Are we ever going to get it to do this? So then the school of thought like shifted over here where they're like, oh, maybe we actually need to lengthen. But then it was almost, I don't know if you've noticed this too, Karah, but I'm like, now like we're throwing out the baby with the bathwater. I'm like, now everyone's like, oh, never Kegel, right? And I'm like, okay, that doesn't even make sense, right? Like again, the muscles have to go through their range of motion. So it's just, we see, once we can restill that normal length, we want to strengthen. And if we don't strengthen, and then we have to go outside of the pelvis, because it's not just the pelvic floor doesn't work in isolation. Like as pelvic PTs, we're putting on our detective hat and we got to figure out, why did the pelvic floor become hypertonic or, in the first place? Let's fix it. But if we don't go deeper and find the underlying contributing factors, and that is mind, body, spirit, right? All the things that come in, they're going to be back in our office. And what we do isn't going to last. So that's where we start looking at like, oh my gosh, the foot influences the pelvis and the jaw and the head and the thoughts and neurotags and breathing and all the things.
100%. It's like, yes, it's tight. Why is it tight, right? Going that extra step. Why is it tight? Yeah.
So I don't know if that helps, hopefully.
Yep, thank you. We have a question from Stephanie Alano, LMFT, also from Rouse. Can we refer if the client or therapist suspects PMDD or an autoimmune disorder?
I mean, I would say for me, yes, of course, within my scope, especially if they have symptoms, because with those things, it does require more holistic care. And I work with acupuncturists, DOs in my community, folks that can manage maybe more of the systemic lens of some of those things. But just also knowing that every system influences the other. I've had folks come in with those disorders, and for them to be able to connect to their body in a way that's beyond fear and pain, and to feel just, yeah, more conscious, more coordinated, to get blood flow, to get movement in some of these areas, I have seen symptoms improve.
Yes, I absolutely, like when we come back to like that full systems approach too, so many of our patients already are manifesting some of these issues. We have a high volume of people who have autoimmune issues. For example, I even have Hashimoto's. So like thyroid dysfunction, if you, most Hashimoto's will eventually tip over into a hypothyroid presentation, and that can be an underlying perpetuating factor for muscle spasm. So as the PTs, we're like also helping to connect dots too, where we're like, okay, we may not be the specialist who obviously is going to treat the autoimmune, but here's how it connects to your pelvic floor and all your fascia throughout the body and other muscles. And so, we become, which I know we're going to talk about like scope of practice and stuff like that, but we almost become these case managers where we can help connect dots. Part of that is our model. Most pelvic PTs nowadays will treat patients for an hour, and we have the ability and the time, but we also need the training to be able, and that's part of what my goal is too, is to also, like, with new generations of PTs, like, let's be very holistic, because if it's being missed by the physicians who only have 15 minutes with these patients, like, it's up to us to also, help these patients with a case management perspective. So PMDD, to answer that, PMDD, I also have suffered with that. And so typically there is hormonal issues, instability. It's, there are different schools of thought, but definitely with extreme drop of estrogen that happens for some people's brains, that will create a chemical imbalance on the brain during that time. So you have to be working again with like a really good endocrinologist or doctor who understands that. But it's also linked commonly, like when you have endocrine dysfunction and then other issues with hormonal imbalance, very commonly, you're going to see a presentation of other pelvic pain syndromes as well, like endometriosis. And so when you have any inflammatory condition in the body, muscle reacts in the presence of inflammation, and the fascia does as well through this reflex that emerges. And so the fascia itself can be a huge pain generator, the pelvic floor, all the external musculature. So yes, I think we would play a role. Absolutely. I would say refer them in, because we're going to probably find stuff and connect dots that would have been missed.
Excellent. We got a couple of more PT specific questions, and then we're going to open it up to everyone in the panel. But speaking of scope of practice, can you help us understand, what conditions that you treat that sex therapists and mental health providers may not realize that is within your scope?
I mean, I don't want to make any assumptions, but probably a lot of people are already aware. The first ones that come to mind that would be more likely with someone coming to therapy for sex would be things like vaginismus, vulvodynia. There's these, fancy terms, and yes, there's some specificity within each of them, but a lot of these are just the barriers to penetrative sex. So it can be that the muscle is tight, spasming, painful. There can actually be hormonal components, specifically with the tissue at the vestibule, that can be hormonally driven. It can be neuroproliferative. It can be from birth. I forget what the word is for that, but there can be different factors. So yeah, that's the first thing that comes to mind, is just being most direct. And then I think a lot of people don't realize that pelvic PTs can work with people with penises. And so just to name that as well, that erectile dysfunction, penile pain, things of that nature. And again, just to name everything in between, because I feel like the intersex population isn't mentioned enough, and how like there's a diversity of how genitalia can show up. But at the end of the day, everyone has a pelvic floor, and those muscles do affect this system. So that's probably what I would say.
Yes, I love all that. I mean, everyone has a pelvis, right? So at one point, I think everyone's going to experience something. So I think a couple of the things I would add would be GI. Like, we can treat a ton of GI dysfunction. So pelvic dysfunction isn't just limited to the pelvic bowl itself. So we really truly are like holistic whole body therapists. And so we look at, there's a particular type of additional training that we can integrate with. So it's called visceral manipulation. And so we look at fascia that surrounds organs. So like GI is like a super easy one, but it can go all the way up to, beyond the pelvic cavity as well, even brain. So that's an osteopathic technique that came out of France. And so it's something that we integrate within our practices, where we go and we actually treat like the fascia. There are multiple layers of fascia, which is connective tissue. Think of spider web, like three-dimensional collagen elastin fibers around every organ, nerve, vessel, bone we have in our body. So when, again, inflammation and inflammatory component is going, that fascia will change. So we'll work with that. So organs can actually, they need to breathe, move, shift, glide, slide, not just the muscles. So we work with that. Cranial sacral is another component that we integrate here too. So we will work on with the head, the cranial bones themselves. So there actually can be movement later in life. And so there's a rhythm of the cerebral spinal fluid actually that comes off the brain through the spinal cord. And so if there's an interruption in that, there's techniques that we as pelvic PT, well, not every pelvic PT, this is where you also have to just ask, because every pelvic PT is going to have unique training, and every practice might have a little bit of a different specialty within, the niche of pelvic PT. But the cranial sacral is incredibly calming for the nervous system, and to get that cerebral spinal fluid moving again that bathes the spinal cord and every nerve coming off of the spinal cord. So, I think that's what, like, the lens of what you might think. And even when most patients come in, they're like, I had no idea that this is what this was going to be like. And just, wow, why isn't everybody else, right, like, talking about this? So, yeah, I think.
I'll just add to that too, because also at our practice, we do practice visceral fascial mobilization. We trained with Ramona Horton through Herman and Wallace under that work.
Love it.
And what blew my mind that I learned and actually have seen results with is actually treating GERD, which I won't get into the whole mechanisms, but there is a mechanical, so acid reflux. And that actually can also be a yellow flag as well if someone hasn't disclosed anything about their pelvic floor health, but they mentioned that they have significant acid reflux or even a history of significant asthma. These are things I have found to correlate with pelvic dysfunction, because the respiratory diaphragm is so connected to the pelvic floor that they have had other reasons in their body to constantly tense their diaphragm, asthma, right, at these things that are inflammatory or irritating to that part of the body, then that often correlates with pelvic dysfunction. So those ones have definitely blown my mind, which I never thought would be in my scope as a PT.
Yes. Oh my gosh, I just thought of another one. Sorry. That is so fascinating, right? Like that. I wish honestly years ago that I had the training or knew somebody, because again, I've been around for a long time. So I suffered infertility and related to endometriosis. So I think this is another now treatment area that is starting to expand and boom in pelvic health. So we can help with infertility. That is related to, again, back to the visceral manipulation. So there was a study that was done, which is amazing. And they took women who had blocked fallopian tubes so weren't able to get pregnant. And that was proven through hysterosalpingogram. And they tried to inject dye into the tubes, blocked. And then they underwent very specific pelvic therapy, integrating visceral work to unblock the tubes and change, right, all the fascial perspective, muscle, fibrotic stuff. And they showed through evidence of that hysterosalpingogram that they opened the tubes. Like, you can change fertility. We play a role. I'm not going to say like we obviously are going to work in a bigger team support with like IVF doctors too. But that is another one that, like, as it's hit, and I've learned through my own journey, I'm like, wow, how wonderful, right? That also we can add that to the table.
Thank you. And so I'd mentioned this on Wednesday during the training, but just like a side note, as someone who went through academia and still kind of in it and just was a floating head, I'm starting to realize how compartmentalized I was from my body. And just this is really fascinating. My mind is like spinning in all the ways that I can learn more about this thing that's attached to me. So for sex therapists, what sort of questions are you asking during intake or throughout your time with your clients that might reveal pelvic floor issues that they haven't connected themselves? Like, what are you listening for? They're like, oh, pelvic PT would be a good person to talk to.
Yeah. Oh, sorry, Marjorie. Oh, okay. Yeah, I was actually going to comment on the last discussion real quick, but I can actually attest to the visceral fascia manipulation technique because my pelvic floor physical therapist has helped me with a rare condition, and I was not expecting any sort of improvement within the first session. And I was like, okay, like I don't expect it at all. But then after the first session, I didn't feel the discomfort that I was feeling. And I was like, whether it's amazing placebo effect or or it would just genuinely worked, which I think it genuinely worked. it was just fascinating. So, and I haven't been able to find a provider to help me relieve that discomfort. So very happy about that. I'll put another question in the chat too, that if we have time, you can both talk about this, but like, how do you know if someone needs craniosacral therapy? Is that something that you would recommend for everybody, or is it only if they're experiencing high intense anxiety? So yeah, I'm going to table that. But to answer your question, David, I typically ask about if they experience any sort of physical health issues, if they're experiencing any pain during sex, not just pain as well, but like self-esteem issues, any past trauma. Especially, I do flag for like endometriosis or any internal things that they experience, GI issues too. And if they are working in tandem with another practitioner, like do they have a GI? Have they ever seen a pelvic floor physical therapist? Do they experience difficulty with incontinence? Are they having difficulty even like putting words to identify what it is they're experiencing? So that's like one part. The other thing too I would ask is what are the origins of the issues? When did it start? How much distress has this caused? Is it affecting your daily life? Are you thinking about it all the time? Are you thinking about it constantly? How long does the pain last for? What type of pain it is? So I do preface all of these questions with I am not a medical practitioner and I'm not a pelvic floor physical therapist, but I do know someone who I can uh, connect you with that can help you with this and talk about it further. And then the last part here too that I would also ask clients is what's your relationship with your pelvic area, your pelvic region, your genitals, and what's your body image relationship as well, just in general. Yeah, and then I can pass it over to Marjorie if you had anything they want to add.
Sure. Yeah. I mean, that was really comprehensive. And absolutely a lot of along the same lines of what I would ask, especially around, you know, some of, again, talking about scope of practice, you know, as mental health practitioners, but also, of course, there's the mind, like body, spirit, as you were talking about earlier, Dr. Karah, and of course, it's all connected. But checking in around, you know, it's not only like current sexual functioning, but sexual functioning over the life. What has the relationship been like over their life with, you know, with their genitalia, with, I mean, you don't know how many people I'm like, do you masturbate? And they're like, no. And I'm like, okay, homework time. You know, because we need to know how, like, is it an anxiety, like mental anxiety thing, or is it coming from the body and then resulting in those emotional, like mental anxiety sort of symptoms? Because it can be either way. And then, of course, you know, we have some really great assessments around to use around sexual functioning. And I can't remember. I am somebody with chronic pain and chronic illness issues myself, and we have all sorts of resources for questioning around like, okay, well, how often does this happen? What does it look like when it happens? Are there particular triggers? Are are you able to communicate with your partner about these things? You know, because of course there can also be stress in relationships that can result in things that feel differently in their bodies. And of course, again, scope of practice, checking in around, you know, like, have they thought about their pelvic floor? A lot of people don't really think about their pelvic floor as a concept at all. And like David, you were saying, a lot of times people are just kind of going through life, and we're spending a lot of our time up here, and we're not spending a lot of time in our bodies. And so, sort of like checking in around how that connection is happening, if it's happening, and how we can support that more so that we can get better ideas of what is actually occurring inside of them. And so we can offer the resources or the referrals that are appropriate.
Yes.
Love it. And then for the sex therapists, how are you helping prepare patients or clients that are about to go to their first pelvic floor physical therapy appointment when they have a trauma history or a sexual trauma history specifically?
Well, I think it kind of depends upon, because of course there can be, I I prefer to be able to be in contact with with the pelvic floor physical therapist, right? Like I like having the sort of like we are a team and we're supporting our clients. Obviously, I check in with clients to make sure that that's something that they're comfortable with, right? We do a release of information, all of that sort of stuff. But I also check in with the client, like, okay, like, here are some of the things that we've discussed that would be really useful. Again, I work with a lot of folks with like brain fog and chronic illness issues. So, like, taking notes, like, are you taking notes? Do you want me to take notes and I can send them to you? Like, or do you want me to, is there anything in particular that maybe you feel uncomfortable bringing up with somebody that you've never actually met before and you want me to help like communicate some of those things sort of like behind the scenes so that you can walk in and know you're going to be, respected and held in the way that you would want to be without actually having to speak that out in the space. Because again, medical trauma, sometimes people are uncomfortable with that. But yeah, so I would definitely spend part of a session ahead of time talking about some of the things that I know that they will be asked so that we can talk about it ahead of time so that they can come in prepared for what they need.
Yeah, and speaking, oh, sorry. Yeah.
No,
Oh,
I was
no,
just gonna say, that's so helpful, like all that information too, if we can have that true collaboration back and forth even before, whether that's written report or on a quick phone call, which I prefer in person, to debrief, because if there is trauma there, we need to know if there are going to be certain triggers, right? So,
no.
I mean, I had a patient once that none of her trauma history was divulged to me, and then she dissociated on the table with me. Like, and so her therapist absolutely should have been there that first, right? And I should have known, but she didn't, the patient didn't share. I was very early in my practice. So I've learned since, right? Also a lot. I wasn't even trauma informed back then. So like that, that collaboration is so critical. Then I didn't mean to interrupt, but I just wanted to say thank you for saying all that. And then just call us, please.
Yeah,
You know?
absolutely. Oh, sorry. Was there someone else?
No, go for it.
Oh, okay. Yeah. And seconding everything that Marjorie and Julie, Dr. Sarton just talked about. But yes, I also like to tell clients too that I also provide the case collaboration piece, and any referral that I provide to my clients, I have personally vetted them already. So I make sure that the practitioners I connect with are people who align with my therapeutic approaches, who I know will take care of my clients, and that they are also open to doing that case collaboration piece, because it's so important that we are working as an interdisciplinary team and that we can help each other out when needed. And as Dr. Sarton just talked about, like, letting you know, hey, these are the triggers, by the way, this is what we're working on, and making sure that our goals are aligned with each other. What I tell clients that they can expect is every case is going to be different. Every frequency, duration, how long you're going to be there is going to vary based on your specific case. So definitely let the consult with the PT first. And the biggest thing I always tell clients too is have a consultation call with the potential pelvic floor physical therapist, ensuring that you feel very supportive, vulnerable, and safe. And if you do not, it's okay to not proceed. I will provide you with another referral because you are getting very deep and vulnerable with them as well. And then I also let them know too, like, not every person is going to need internal work. A lot of times they are worried about that medical piece of like, oh my gosh, like I don't even feel comfortable inserting a finger within myself. So how am I going to let somebody else do that? And so I do preface it with it's going to vary based on your case. You may not even need to do internal work. And a lot of times with the PTs that I send you, they already understand that the nuance in those levels and making sure that you are comfortable every step of the way. So I try to reassure them, letting them know. I also, if they have questions about it, I have gone to pelvic floor physical therapy myself, so I know what it's like to be in that room as well. Yeah, thank you. I will have to hop off as well. So if anyone has any questions, please feel free to email me after. David has uh, done the pleasure of providing the websites to all of our bios, so feel free to reach out. And I love collaborating with other physical therapists and mental health therapists as well. And thank you so much for being here.
Thanks, Emma. Take care.
Bye.
Yeah, we're totally doing another one of these, and probably kind of on a repeated cycle, because this is really fascinating, and a lot of therapists and pelvic PTs and clients have just been sharing a lot of interest in this. So thanks for hanging out with us. We're gonna keep going. Another thing I'll add is some of my clients in the past have asked the pelvic PT ahead of time, can I bring my partner with me to the first session or two? And that's been really, really helpful and really lovely experience of just like kind of the crossing that threshold a little bit. Um, so for the pelvic PTs, can you walk us through a first session that someone may expect? I know it's going to vary, and I also love that the repeated message of this is that we're beyond the binary. But in general, like what could someone expect?
Sure. I think with me, I can have an idea, and it's, of course, even the first
Right.
session is so variable depending on the person in front of me. I mean, I place a lot of value in attunement and aligning with what I perceive or ask after this person's beliefs to be. So, the first session, if that person needs to be heard, sometimes it's actually 30 minutes of hearing their story, which I've even had clients where I don't even have them on the table and just being heard in a little bit of education, they come back and report things have already felt better. So, I prefer to not have a strict formula because I like having the fluidity and the flexibility to show up for the person in front of me. But my goals are to really hear their story and make sure they're not rushed and feeling heard with that. Um, I really like to ask after what their goals and expectations are for this session and for treatment. I'm very collaborative, so it's not me saying, here's the protocol, here's how it's going to be. Unless I have a really cerebral person who like needs that for safety, then I'm happy to like go there with them on that. And then, yeah, my goals are to do some assessment, right? If I am able to and when indicated, that can be everything from movement tests to looking at how they're breathing, potentially internal, potentially not. I'm really grateful Emerald mentioned that that is not necessary ever. I've been able to treat people without ever doing internal work. And I think that can be really empowering. Um, but yeah, definitely like hands-on, both assessment and treatment, right? I want people to at least feel how I treat the first day and hopefully create some change for the better if possible so that they understand what it would be like and, can choose to return. But I'm very much, yeah, the questions, the assessment, and then education and giving them one or two things to walk away with. I want them to already feel empowered. I'm really big on how are you going to maintain at home? Again, attuning to what are their habits, what are they willing to do. I'm not going to force a 30-minute exercise routine on someone. It's again the belief piece. It's like we can know the answer, but if you're not going to actually do the whatever exercises I give you, let's figure out what that's about and what's going to actually work for you. So yeah, I would say that's typically how I work with people in the first session.
Yes, we're very similar. So I think the number one thing is we create space to hear the story that probably hasn't been honored. Again, in like the typical medical model with physicians, they on average are given 15 minutes. And there is for pelvic floor dysfunction, it gets complex quickly. And so there is no way truly the story has been heard. So I always say like that first visit, I mean, sometimes it is 55 minutes literally, right? Of listening to them speak. And then also that allows us to really understand all the facets too, and then start connecting those dots for the patient. And then it's a dialogue back and forth. So of the validation and the holding the space for them and then just trying the educational piece too. If it's a more simple case, and it's not like a patient that sometimes brings in like 2 binders of medical history, right? And we're like, okay, this is streamlined and we can get through what we do the first part, that true subjective understanding their history. Then like we go from we want the body tells a story, so we get them still with like sport, just depending on clothing perspective, but we want some of the clothing off to look and see like what's happening like from the external perspective too. And so what's happening then, how do you hold yourself, right? Is the posture a response of mechanical things plus trauma? So we're just putting pieces together. And then there's a hands-on component, just like Karah was saying too. There is no way we can get through the entire body in one session. So we'll typically, like we always like to start in our clinic with the abdominal wall. It's a safe area that can tell you a lot. That pelvic, the fascia of the abdominal wall goes right into the pelvic floor. You'll make changes without going internal. We look again like spinal, hip, all the biomechanical stuff, breathing, just like you said, and then and nervous system. I mean, if that patient already, maybe that's where we start too, right? And we start up on the head and neck. We look at the vagus nerve. We look at dysfunction, like as the vagus nerve, which is the longest cranial nerve we have, and it's plays a huge role with calming the autonomic nervous system. So if you have dysfunction up here and you have tight fascia and muscle here, as that nerve runs through the neck and down in under the sternum and on its way down, because it innervates the lungs and the heart and the gut, right? Like if it's being restricted through its path, right? We can teach them breathing all we want, but let's give that nerve a little love and give it a chance to recalibrate differently too, from a mechanical standpoint. So, and then we're just educating as we go, educating. So, you know, if we have somebody that drives in from a long distance or flies in to see us, we absolutely always do a minimum of 2 hours with our eval, because again, it gets to be a lot. And so that helps the therapist pace as well. So our nervous system can be down here and we can be good for, you know, as a good model and, you know, help for that patient. So.
Thank you. And Marjorie, what should people expect on like a first session or 3 when they come to you saying, you know, I need a sex therapist to talk about pain during sex or anything that could be related to pelvic floor PT?
Okay. And again, it really depends, right, upon everybody is different. Everybody is different and every body is different. And so, you know, I always want to make sure that that comes forward. The way that I generally like to start working with clients is that I like to start with what I refer to as what's on fire. So, you know, obviously people come in with, you know, oh, I want to work on this, I want to work on that. But sometimes people come in and there's something that is kind of in crisis mode. And I want to make sure that I address that kind of immediately as I'm doing, you know, the intake assessment stuff. As I'm doing the other stuff, I want to see if there's something that, you know, whether it's skills building, whether it's working on that mind-body connection, so that we can get a better sense of what it is that's actually happening. And of course, you know, as with any client, it's going to be about building that ease, and that relational piece as well. Because sometimes people come in and they know exactly what's going on. They're like, oh no, I'm having pain. I want to work on this pain. This is how it's showing up, and this is when it showed up. And you know, they have all of it, you know, all of it sort of already written down, and that's great. And I'm happy with that. If I, you know, if they have that. But some people aren't. Some people are just like, you know, I'm not interested in my partner anymore. And it's like, okay, let's dig into that. What does that mean? When did that start? You know, did something happen relationally? How does that feel in your body, right? Like dropping into the somatic piece as well, to see if, you know, is it pain? Is it tightness? Is it aversion? Is there something else happening? And so really I'm kind of like almost juggling all of it. It's like, okay, cool. We're going to check in around what's happening in the moment in the room, sort of like in your body. We're also going to talk about like, okay, is there a particular time where that happened? Can you think of anything having to do with that body part, or, you know, that activity that comes up for you as far as maybe a trauma history or a memory that can be sort of being brought forward? And of course, if there are things coming up and it's like, oh, that sounds like it might actually be like a physical functioning issue, bringing up that, like, of course, I'm happy to support in what parts I can, but like it does sound like maybe they need to do a little bit of checking in around, having an assessment from somebody who deals with more of the physical aspect as well.
Love it. We are almost out of time. We could go on and on and on, and like each one of these could be its own workshop. I do want to ask one question in the chat. Are there any special considerations when referring folks with Ehlers-Danlos or hypermobility concerns?
I mean, for me, I'm really fascinated. There's a lot I could say on this topic. There's actually some new research coming out around, again, it's like which direction, but how this can be correlated with vagus nerve dysregulation and nervous system dysregulation. So, when anyone is coming in with that as a diagnosis, I check with everyone, but I want to know how their nervous system is being supported and just being more holistic. And then from a PT perspective and just even like biomechanically and with exercise. I'm very particular around what state is their nervous system in when we are exercising. Because a lot of times I will hear the rhetoric that they're like, oh, I easily get flared because I'm really loosey-goosey, and that can be part of it. But now there's some research to suggest that actually if they're in a more hypervigilant state, yes, the biomechanics can be a piece. I guess what I'm trying to get at is the nervous system is very important with this population. And then again, also biomechanically, like making sure they have really good proprioception. So these are people that I'm going to be really particular around the type of exercise and how are their joints and input. I'm trained in a unique modality called dynamic neuromuscular stability, DNS, and that work has been profound for my people that are hypermobile. So really stabilizing at the core and then developmentally through integrative patterns. So yeah, I'll leave it at that, but that's a population I'm very passionate about.
Yeah, it's such a wonderful question because I think this population has been mismanaged for so long and misunderstood. And so, and it comes with a cluster of other things as well. Typically, like we'll see with EDS, they also have something called mast cell activation syndrome and POTS. And so there's a big spectrum that exists with EDS, and then there's 4 different subcomponent types. So the hypermobiles, you just want to make sure that the PT that you are referring to does have appropriate training, because this is not training that we're getting in PT school. So this would all be post-grad training specifically. I think I love that you do DNS. One of my therapists also has done DNS, and it's beautiful. And we have red cord, because you need a neuro background and perspective truly to work with this population. And this really is not integrated in the pelvic floor training. So it's like a little orphan over here that's coming in that I'm so happy that it's getting more attention. You know, I had an EDS, one of my first EDS patients. She was so severe. She came in a power wheelchair. She was so hypermobile. She would not just sublux, but literally dislocate. So like shoulders, hips, ribs. Now we got to think of the diaphragm. I'm like, I had to really be on my game to make sure I was competent to treat her, because like that can influence breathing, right? Cranial instability, like all of that in that severe case. That was a lot. So also just matching up, you know, the experience of your PT with those patients. And because there's that broad spectrum of the presentation, I think is just another piece that needs to happen.
Thank you. I'm saving the chat because I want to include it, because I see some great, like Dr. Baylor Travis put in a YouTube link. And then there's some great questions for all of us to chew on. Yeah, let's do this again. Can you put in the chat, people that are viewers, if you want us to do this again, just like a thumbs up or something like that, just to kind of get a sense of this. But yeah, we have a lot of people that have signed up for the recording, and I think we can kind of narrow in on certain different topics and jump in from there. Any last things that you want to add before we say goodbye to our lovely folks?
I just want to quickly say, because I thought the other questions were really interesting. And so whoever asked those, if they want to email me, like I'm really open to one-on-one. I have some very like strong opinions on like the nonverbal thing because of some of my somatic training. I feel like really called to answer that question, but I don't think we have time. So just if anyone does want to just talk to me one-on-one, email or a chat, I would be really happy to do so.
Wonderful. We can make that like a focus on one of the next ones. You know.
I just thank you, everyone that showed up, because we need you in the pelvic floor world too. Like yeah, it is huge. And so, I mean, we always joke, all my therapists and I here, we're like, oh, we don't have psych degrees, but we really need them. Like, so we need you guys.
I always joke, I'm like, if I had unlimited time and money, I would also go back and get
Right.
a psychotherapy
Yes.
degree, and not to like steal clients, but literally just to make me a better PT, because it's
Right.
wild to me. Again, this binary of mind and body, it's like there's no way. I'm always dealing with people's material. And so, yes, thank you all, because I look to therapists as like my guiding for all my continuing ed at this point. Like that's where I feel like I'm deepening my work as a PT.
Wonderful. Well, thank you all. We will be in touch. Feel free to join our newsletter or just come around and say hi. We will talk. Take care. Bye, everyone.